السلام عليكم. صباح الخير، مساء الخير. احنا بعد الظهر بقى. طبعا بشكر استاذ دكتور احمد حازم على المقدمه والمباركه الجميله دي، وبشكر حضراتكم على التواجد. احنا هنتكلم عن في اول سيشن عن الرول اوف هيب ارثروسكوبي ان femoral-acetabular impingement. Femoral-acetabular impingement is a common cause of hip pain and joint damage, usually occur in young and active patients, can lead to degenerative osteoarthritis, and early diagnosis and treatment equal hip preservation usually. To define femoral-acetabular impingement, it's an abnormal contact between the femoral head-neck junction and the acetabular rim with the labrum in between, usually caused by altered bone morphology, the repetitive impingement causing progressive damage to the labrum, to the cartilage, and the chondrolabral junction. These are the types of femoral-acetabular impingement, as we can see, whether it is cam type or pincer type or mixed, as we will see in the demo. The cam type is the pathology over the head-neck junction, while the pincer is acetabular side over coverage. Here we can see on this demo the shape of the cam lesion. As you can see, the osseous hump over the head-neck junction, while it's impinging and causing damage of the chondrolabral junction. And on the other video, you'll see the over coverage of the acetabulum, which cause abutment of the labrum over the neck, the femoral neck, and causing labral pathology. And sometimes it may be mixed type, cam and pincer, in same patient. To diagnose femoral-acetabular impingement, you should go properly to discuss with the patient, ask about the symptoms, the clinical signs, and latest is to look for the radiological imaging and findings. The main symptoms, usually the patient is complaining of C sign, mainly typically groin or inguinal region. Sometimes it refers to the lateral hip, buttocks, or thigh. Usually the patient is complaining of clicking, catching, or giving way. And we can use a diagnostic aid to locally inject intra-articular lidocaine to make sure that the pathology is intra-articular pathology. As you know that the hip region is very sophisticated, complicated. The pain may be from other side, like sacroiliitis, piriform syndrome, or from intra-articular pathology. Physical examination includes the most sensitive test, which is impingement test, flexion, adduction, internal rotation. Once you suspect that the patient has impingement, femoral-acetabular impingement, this test is highly sensitive to do flexion, adduction of the hip, and internal rotation. If it's painful or clicking occur, usually it is sensitive that there is impingement or labral pathology. The other test is flexion, abduction, external rotation, and its interpretation. If the pain is anterior, it's intra-articular pathology. If the pain is at the posterior hip, it's sacroiliitis. Or the external rotation, if it's limited, so there is iliopsoas tendonitis or irritation. Usually we are looking after that for the imaging, the plain X-ray, AP, and done 45 view. Also other views like false profile, cross table, or frog lateral. Here we can see in AP view the cam lesion over the femoral head-neck junction. And the pincer lesion, there is increase in the lateral central edge angle and over coverage of the acetabulum. The dumb view usually we can see the cam lesion, and we measure here the alpha angle, as you can see on the image on the X-ray. The alpha angle, when it increases more than 50, usually there is a cam lesion, and it should be diagnosed carefully later on with CT scan and MRI, as we will see. CT scan can give us detailed 3D assessment of the morphology of the site of the cam or pincer lesion to precisely do preoperative planning for evaluation of the bony lesion. Whether to do MRI or do MR direct arthrography. Recently we used to do MR arthrography, but there is different studies trying to compare a high resolution MRI to the MR arthrography. If you see a patient with normal MRI or MRI hip, you will not guarantee exclude the intra-articular pathology. Sometimes it is not seen the labral tear or chondral damage in ordinary MRI, so we asked for direct arthrography with radial sequence cuts to make sure where is the labral tear and where is the chondral damage. And sometimes we are asking for high resolution MRI to avoid the complications of local intra-articular dye injection. The MR arthrography is better to detect the labral tear, the paralabral cyst, the chondral damage, and impingement-related cysts. Hip arthroscopy has seen an exponential increase in procedure worldwide. It's a surgical technique to give us a minimally invasive approach to manage the femoroacetabular impingement and its sequelae. The procedure has a very steep learning curve and requires significant experience. The success of the procedure depends on precise patient selection, meticulous preoperative planning, refined surgical technique, as well as the respect of anatomy and soft tissue. Patient positioning in hip arthroscopy, as we can see, it can be whether supine or some surgeons prefer lateral decubitus. Usually we are using an orthopedic traction table. There is a specific hip arthroscopy traction table, but it's not available here. Correct positioning is essential for surgical safety and access. Usually we can start with a peripheral or central compartment, as we will see in the video. Central compartment usually require this traction, using the traction, whether with use of the post or with Trendelenburg position to avoid the post complication for the compression of pudendal nerve. Fluoroscopy, usually we are using it inside the operation room to assess the direct access to the hip. The portals of hip arthroscopy, as we can see, the viewing anterolateral portal and working anterior portal, and we are using the distal anterolateral portal for anchor placement. We start with interportal capsulotomy between the anterolateral and anterior portal to make the movement of the instruments easier, facilitate visualization and navigation, and usually we are doing a T-shaped capsulotomy to access the cam lesion and head neck junction. To be repaired or not after surgery, it's debatable to repair the capsulotomy or not after finishing the hip arthroscopy. First of all, we are going to do a diagnostic hip arthroscopy. As here we can see, there is on the right side, there is a femoral head. On the left side, there is acetabulum and there is labral tear. We are probing it to do a labral assessment, and chondral, if there is chondral damage, we assess it to do whether labral debridement, repair, or reconstruction, to do chondroplasty and femoroplasty later on, as we will see. This is the sequence of labral repair. As we can see in the video, we are drilling for anchor placement, and we are putting the anchor. It's according to surgeon preference. Usually, we are using all suture anchor recently, then shuttle the sutures around the labrum to repair it and tie the suture over the acetabular side. As we can see here, after labral debridement. Then we will go for peripheral compartment to do femoroplasty or osteochondroplasty of the osseous hump of the cam lesion, and we will do a dynamic assessment after finishing the osteochondroplasty to assess if there is no impingement after finishing the femoroplasty, as we can see here in such video after cam resection, and assess also labral integrity after repair. Labral reconstruction is indicated in irreparable labral tear, indegenerated, complex, or calcified labrum. Also, post-debridement deficiency, if the patient went for debridement and there is no labrum to repair it, we could look for later on solution, recent trend solution, as we will see later on with our professor, Dr. Hatem, revision surgeries, failed prior repair, or dysfunctional residual labrum. Thank you.
دكتور حاتم هيكلمنا على كل شيء جديد. دايما بيكلمنا على كل شيء جديد في الهيب سيرجري، فهيكلمنا على النيو ترندز بتاعه الليبرال مانجمنت which is evolving من debridement to repair to reconstruction to augmentation nowadays. انا عارف ان اغلب الناس اللي في القاعه هنا interested في موضوع اليونج ادلت هيب بريزرفيشن، واحب ان انا اعمل اناونسمنت بس بسيط ان الكورس بتاعنا السكند كادافيريك ورك شوب على اليونج ادلت هيب بريزرفيشن والهيب ارثروسكوبي في القصر العيني ساتلد الديتس بتاعتنا على يوم 28 و29 جانوري 2026 ان شاء الله، يعني كمان شهرين. فاحب ان حضراتكم تكونوا موجودين معانا، وهتنزل الاناونسمنتس في اليومين الجايين على السوشيال ميديا وعلى الويب سايت بتاع القصر العيني ان شاء الله.
هنا مش ظاهرة، المفروض تظهر لي شو سكرين تاني
entire screen.
امتياز بالظبط. تمام فول سكرين. ماشي ثانية.
Screen.
يس
تمام. شكرا معلش. Yeah, it's coming. And coming from Asyut yesterday, I forgot my laptop. So this is my borrowed laptop, but luckily I was able to download the lecture and modify and work on it. Alhamdulillah. But it was not a nice feeling. Anyway, thank you, Ahmed, for inviting me here. It's always a pleasure to be among friends, Muhammad, Radi, Walid. This is just to mention some of the things we're doing now for the labrum, whether it's a repair or reconstruction. Debridements, much less now. We're trying to preserve as much as possible. So the aim is to just see how to manage labral pathology, whether repair, reconstruction, or augmentation. So the idea is to repair is we should preserve the labrum. The labrum has a very important function. It maintains the seal of the hip, which is necessary for the stability of the joint. So the research is very obvious that if you don't have the labrum, the actual joint is not stable and it will move out of its place very quickly. So the vacuum effect is important. One of the things we see on the lateral view when you have an FAI is you see the vacuum sign because of the lack of the labral seal, the air there. So if you have a good quality labrum, the plan is always to repair the labrum. So what are the steps of doing that? First, we decompress it by doing the acetabuloplasty. The question that comes out after that, should we separate the labrum or not, which we'll mention. What type of anchors should we use for the labrum? Is it knotted or knotless? Do we use old suture or solid anchors? But now the tendency is all the time we're going for old suture anchors because of the size of the old suture anchors and the safety. If penetration happens, you can always retract all suture anchors. But if it's a PEEK or metal anchor, that's a problem that can damage the joint. So now we always use all suture anchors. Do you go around the labrum or through, which is the labral base refixation? I'll tell you the evidence. And do we do any chondroplasty for that? One of the very nice actually articles published is the compression flip test that published by Dienst. Is early on when you're still in the peripheral compartment, you can know where the labral tear is by pressuring the labrum. And if it flips, then there is a labral tear. So type 1 is no flip. If there's intact, nothing happens to the labrum, you'll find it bouncy. When there's a tear, you'll find that it starts to go deep inside. And if it's actually a large tear, it starts to completely buckle up, as you see in the picture. And opposite to that is in the pincer, when you have too much bone covering the labrum, then there is a -1, which nothing happens. You're actually pressuring on bone. So this is the flip test, and I find it very useful to determine where the tear is. Okay. So decompression of the labrum is very important by removing the extra bone subspinous area. That's important while preserving the labrum itself, especially in the ossified form, which initially you might think there's not enough labral tissue, but if you gradually do it and you take the bone from under the labrum, eventually you can end up in most of the cases with a good quality labrum that you just repair. You don't need to replace or reconstruct. And a lot of the time, when you have an ossified labrum like this and a lot of bone behind it, the MRI may not detect a labral tear, although there is a tear, because there is an actual bone inside covering the labrum. So this is something you have to keep an eye for. And as I said, it's about decompression. Now, after removal of the bone, you see that the labrum is quite movable, and you can take it back into place, and you continue your decompression all over to allow the recession to happen. Sometimes, as you see here in the labrum, the actual tear is jumping out of the labrum. Now, do we need to detach the labrum? The question is no. This is what used to be happen all the time before. You detach the labrum, you remove the bone, and then you refix the labrum. They found that there is no benefit of doing that. You can easily decompress while maintaining the labrum, and there is actually more adhesions if you detach. So we don't need to do this. Then what type of instruments do you use? We used to use the bird beak, but it's quite thick. It's about 3 millimeters. Now we use the lasso for penetration. It's much thinner. You only do a small puncture, and you can do that under vision. You have to be looking inside to be able to see that you're completely bypassing the labrum. As you see, it's a very small penetration just to allow the needle and the thread to pass, so it maintains the integrity of the chondrolabral junction. After we pass the suture, you can see that we always do the lasso loop. I like to do that. It gives me tension. I'm able to control the eversion and inversion of the labrum, which is important. We always want to maintain inversion to maintain the labral seal at the end. So I always do the lasso loop so I can control exactly the position while I'm tying. Then there's also the knotless anchors, and there is an all suture knotless anchor now, which you can just tension by pulling. And again, the direction of the suture makes you control whether you do eversion or inversion. So of course, we take the loop inside to cause inversion, as you see here. It's easy, it saves time, of course, on doing the knots, and it's quite tight. It's a very strong anchor. It was present in Egypt for a while, but we're missing it. It's gonna come back soon. Now the question is, should we go around the labrum or through labral base refixation? The surgeons, Benjamin Dome, who discovered this, eventually came out and said clinically there's no difference. And that makes sense, because we know once you go around the labrum and you tension it, like in the shoulder pathology, once we do any kind of revision, that suture gets eaten up into the labrum after a while very quickly. So there is no worry that the labrum will remain round. It will not. The suture goes and the triangular shape redevelops again and we've seen that also in revision hip cases. Now the medial anchor, I always do a separate Poulter for that to get the access to very medially, because you need to be there at 3 o'clock. So you do the needle separate anchor, and you're able to get access. If you use the normal anchor, you probably skid off and you'll have problems with the drilling. So you need a much closer vertical angle to do the drilling. This is the anchor while we're doing the drilling. Again, you look inside to make sure you're not drilling inside the joint. One of the most important complications for us, obviously, is you put the anchor inside your joint. All suture, again, it's safe. Even if you drill it out, it's not a problem, because the all suture depends on sticking to the cortex. So if you pull it back, you're outside the joint, so it is safe, and you only have the drill, which is 1.3 millimeters. It's not a problem. It's a K-wire. Now about labral reconstruction, when do we go for that? If it's ossified and calcified beyond repair, if the tissues are very friable, poor quality, if the end part of the labrum is less than 3 millimeters, in most revision surgeries, I think you have to be prepared for that. Of course, if it's osteoarthritic, reduced joint space or low demand, then you may not need it, especially for the higher age groups. Labral augmentation, not to be confused, is the same as reconstruction. It's just we preserve the remaining labrum, which is thin, to keep the ring of the labrum, and just we add the actual labral reconstruction next to it. So augmentation, reconstruction, not much different, except one, you are maintaining the rim of the labrum, and the other is you have a defect and you just fill that out. So you will be planning to do the reconstruction either as 1 or 2 stage. Either if you can see the extensive pincer from the beginning, you have to be prepared to do the reconstruction. in revision cases or in posterolateral ossification, or a 2-stage. If you decide that the labrum is not repairable, you can excise it and come back at a later stage to do the reconstruction. So the graft, either allograft, which is not present in Egypt, or autograft, like we do for ACL. We take the semi-T or gracilis, or some people take the ITB or the peroneus. My preference is either the peroneus or the semi-T. They have good quality tissues. This is an example of a female patient with revision hip. As you can see, the pincer, posterolateral pincer, is extensive. From the beginning, we know that we're going to resect an excessive amount, and unlikely that we will have enough labral tissue. This is the MRI, it's coxa profunda. You can see that the central edge angle is to the maximum, the head coverage is all the way, so we can expect that the labrum is not going to be healthy. This is the MRI. You can see that there is a bump which is hitting the labrum, and you can see how the labrum is actually enfolding on the actual head. So excessive acetabular work. So this is the same way which we try to preserve the labrum, but because you're resecting around 1.5 centimeters of bone, usually that will not allow you to preserve the labral tissue, and actually the remaining labral tissue is very friable. So this is, again, resecting. This is the labrum, and on the right side, acetabulum. On the left side is the neck after removing of the cam and the bump. This is the final resection. We start measuring this. We use the actual suture to measure the distance to plan our labral reconstruction and the length of the graft. You fix it to one point, you make a mark, you go to the other point, and you measure the distance on the suture. So this is the remaining part of the labrum. And the easiest way is to do knotless anchor if you have them. We've done some cases with knotted anchor. It's a bit more complex, but knotless is the easiest because you just hammer it in and it gives you the right position. You start with one at the top, one distal, and then one in the middle to reduce the labrum graft onto the bone. And then you use the remaining sutures from these grafts to try to suture the ends of the reconstruction to the native labrum, because again, you want to get a nice seal at the end. And this is the final view. So here you can see the junction between the labrum and again in the back. So the normal labrum is there. That's the normal labrum on the left and the reconstruction on the right. And the idea is to try to get them as one seal to create the seal over the head. That's our main target, to restore the stability of the hip. And as you can see, the extensive bone resection on both sides of the hip. So for the literature, the results, if you do a good labral reconstruction, are as good. You still get very good results, high MCID with both of them, and equal satisfaction rates. So in summary, always try to prepare. I've taken away debridement now from this lecture because we should not be going into debride just the labrum. This is a short-term solution. And reconstruction if there is a revision or if you have very thin remnant part or ossified labrum. Thank you.
Thank you, Professor Hatem. So we have still 5 minutes. We are ahead of schedule. So let's open for questions for the first 2 lectures, Dr. Muhammad Amr and Dr. Hatem. طيب دكتور
that's why we did the semi-T. Semi-T already, you're draping till here, so we just plan from the beginning the drape till here. In flexion. Normally we work in peripheral compartment, we're working in flexion anyway, we just bend, small incision, and you harvest. So you just need to prepare your harvest and extend your sterilization to distal to the knee. Thickness. So thickness, usually double or triple semi-T, because you want it to be thick, roughly like 8 to 10 millimeters. And the length, we usually do about 30% longer than the expected length. So if you measure 4, you make it 4.6, 4.7 length, so that you don't have too much. Now people are saying that you can just do a longer graft and cut away the extra part of the graft so you don't need to measure as much. This is a way people are suggesting now to make it easier.
دكتور محمد.
Yes, yes. So usually those anchors are double loaded. One of them is going to go through the graft, and so we slide the graft on it and we tie it. Same thing for the distal part. Then we have one free limb, which we try to take between both. So I pass it here, and sometimes I pass it on both, more than once, to tie, to get them sort of to join.
طيب دكتور حاتم كنت عايز اسالك على حاجه. احنا عارفين ان الليبرال تيرز مينلي نوعين، اللي هو البيزل ليبرال تير اللي هو بتيجي مع الكام، والانترا سبستانس ديجنريشن اللي هو ساعات بنخش نلاقي الليبرم زي الاي سي ال لما يكون في انترا سبستانس تيرز بنلاقيه زي فتل كتير. الليبرم لما حضرتك بتلاقي فيه انترا سبستانس ديجنريشن دو يو ريبير ات؟ لو عرفت تخش وتسلكه وتشيل الكام من ايه؟ Do you think that this will function later on?
It depends on the degeneration. Sometimes, like you say, it's degenerated, or we have a cyst in the labrum, and we remove the degenerated tissues. It depends on the remnant that is there. If it's very thin, then it's useless, obviously, to repair something that's like 4 millimeters. That's where the case you need to do a labral augmentation, in which you leave that small rim and you bring the reconstruction or the graft next to it and you tie them together. So, but if there's no point repairing a very thin labrum, it's useless, I think. If you're stuck, obviously, and you haven't planned it, then yes, I would resect that very thin, useless labrum and plan a reconstruction later.
اوكي طيب سؤال بقى لحضراتكم، بما اننا خلصنا الفيمورال استابل امبنجمنت هنخش على تيومرز وكلام كبير بقى. ايه الايج ليميت بتاع ديبرايدمنت، ريبير، ريكونستراكشن، وطبعا الاوجمنتيشن؟ واتس يور ايج ليميت؟ امتى بتعمل ريبير، امتى بتعمل لغايه ايه، انهي ويتش ايج؟
So they used to say, when they started repairing a lot, they used to say we don't repair above 40. So I had my labral repair at 42. So I think that's nonsense, طبعا, right? And we repair cuff tears now at 70, 80, right? We do it for all ages. So it really depends on the tissue quality. If it's healthy labrum, then I would repair it at any age, even 60, 65. If it's the joint is not arthritic, it's just the labrum. But if it's unhealthy, if it's degenerative, then there's no point of repairing it, right? And of course, then you might debride in the older age groups. But I would not debride in a younger age group. Now,
40 يعني
what's
الايج
age?
ليميت؟
40 used to be young, but once you pass 40, then 40 is يعني خلاص. Then young is 50s now. So the young and old changes as you grow older. So someone said always that younger than me is young and older than me is old.
وانا
So that changes
وانا
as
بريفيو
you grow up.
الليترشر لقيت ان الليترشر البيست ارثروسكوبي اوتكم تحت الايج اوف 45. احنا we used to say ان هو تحت 55.
52 now.
بس
They say
50
52 age.
45.
هم لاقوا يعني. لا seriously there are papers on 52 مش عشان انا 52 بقالي
أنا
اسبوعين.
لسه عامل ريفيو، لسه عامل
أسبوع
ريسنت
52.
لسه عامل ريسنت ريفيوز على 2024 ريفيوز ميتا اناليسيس. فهم بيقولوا البروجنوزس بيتر below the age of 45 above the age of 45.
هتغير رأيك.
هنغير
بعد
رأيي.
دي سنتين كده وهتغير رأيك.
انا دلوقتي على الايج ليميت بالظبط.
ايوه. ده المين ثينج طبعا.
Cartilage, I think we'd be more keen. So I think the joint gives us a good clue on the labral management as well. Yeah.
هو بس الغريبه يا دكتور حاتم ان انا I started labor repair مثلا ago مثلا قبل كده قبل مثلا 2020 ما كنتش بريبير. انا بتابع I'm always looking after my patients وكده، والعيانين لغايه دلوقتي اللي انا عملت لهم labral debridement
مبسوطين.
they're doing fine. يعني الليترشر بتقول ان لا الليبر ريبير they do much better، بس انا باللي انا شايفه اللي قدامي لا الليبر ديبرايدمنت يعني انا مش بادفرتايز في الليبر ديبرايدمنت، بس هو احنا وصلنا لمرحله ان الليبر ديبرايدمنت بقى عيب او زي المينيسكتومي او بتاع، لكن احنا actually we do مينيسكتوميز لغايه دلوقتي the patients are doing fine وبتاع، فيعني this is a thought.
انا I think كمان معلش يعني في كذا حاله السن صغير الواحد اضطر يعمل لها labral debridement and his plan was نعمل reconstruction later on and they said they're fine. Why do وده اكيد حضرتك شفت دكتور احمد كده ان هو there's no بعد شهر ونص وكده تلاقي ان هو he's doing fine.
هو actually they recover quicker.
they recover much quicker.
طبعا هي الفكرة بس كلمة fine دي
It's a big طبعا.
it's يعني حاجة وايد شوية، فهو ممكن بتاع debridement is happy البين قليل بس he's not doing sports مثلا، أو لو certain things ما عندوش stability، ف if we test them to the extreme they might not be satisfied but for daily activities he's happy. فأكيد debridement gave good results for a while، يعني هو ده اللي قوم الهيب ارثروسكوبي، بدونها ما كانش قامت، لأن هو كان في very good results مع debridement في الأول قبل ما يعرفوا الليبرال ريبير. ف definitely it had good outcomes. وابتدينا لو انت فاكر early on كانت results equal في الاول، وبعدين البيبرز طلعت قال لك لا
بالظبط لغايه سنه 2000 كانت results مفيش فرق. هو اللي انا مش فاهمه يا دكتور حاتم موضوع ان احنا we went an extreme لغايه الليبرال augmentation in which you reserve الديزيزد tissue and you augment it. يعني هو ده اللي انا مش فاهمه، يعني انا either متهيألي debridement or repair or reconstruction.
الاوجمنتيشن مش هدفه الديزيز، هدفه remaining healthy tissue.
ما هو انت
خلي remaining healthy بتكون انت شلت الديزيز و remaining healthy قليل بس الرينج maintain. whether بقى there is a difference between augmentation and reconstruction I'm not sure لسه، يعني دي I think اللونج تيرم بتاعها ما ظهرش، هي اصعب برضه.
ما اعرفش حضرتك برضه دكتور احمد كنت عملت الليترشر ريفيو، ما اعرفش حضرتك بصيت على النون ارثروبلاستي هيب ريجستري the UK non arthroplasty hip registry هما they have now 6 years of data and so far there is no difference between debridement and repair. يعني عارف most of the North American studies are favoring repair but controversy the UK one does not show a difference. برضه this does not advocate doing a debridement ولكن it's something that we feel in our day-to-day practice.
بس debridement برضه في نقطة هنا، debridement كلمة debridement دي كلمة واسعة. debridement I'm just debriding some unhealthy tissues
ولا أنا
بشيل segment من الرينج. هو ده there is a big difference في كلمة debridement. أنا شلت حتة ولا بس سويته ولسه عندي رينج maintain، لأن ده makes a big difference.
هو دكتور احمد زي ما حضرتك بتقول يعني احنا كان برضو في الاول كان الليبرال ديبرايدمنت ايزير وكان لسه الستيب ليرنينج كيرف بتاع الهيب ارثروسكوبي.
هو انت دلوقتي خلاص بقيت استاذ مساعد.
لا بالعكس
احنا بقى
لا انا بتكلم على لما كنت بسجل الدكتوراه. يعني احنا بقى لنا مثلا بتاع 3 أو 4 سنين معانا دكتور كريم عاطف هو مسجل رساله عن الليبرال ريبير فيرسس ديبرايدمنت، بنقارن حالات اللي كنا بنعمل لها ديبرايدمنت زمان بالريسنتلي الريبير الريزلتس على اللونج تيرم بالنسبه للديبرايدمنت زي ما حضرتك بتقول they are doing well، بس الليبرال ريبير اعتقد ان هم بيتر في يعني الريزلتس الهاريس هيب سكور
اعلى من
والفانكشنال سكورز اعلى في الريبير.
definitely definitely
بالظبط.
قلنا 52 بقى خلاص 52 دلوقتي.
متشكر جدا جدا دكتور حاتم، متشكر يا دكتور محمد. Thank you. And then we'll move to our next chapter أو station which is hip synovial tumors and role of arthroscopic management of synovial chondromatosis. This is a very important issue لأن كتير جدا دكتور محمد عبد الراضي هيقول لنا acute experience في الموضوع ده هون، لأن في حاجة مهمة جدا كتير جدا من الليبرال من الهيب arthroscopies لما بنخش اللي بنكون مش femoral acetabular impingement and then you find a pre-radiological synovial chondromatosis. وحصلت معايا 3-4 مرات ان انا بلاقي البادز بتاعت الساينوفيال chondromatosis موجوده وهو عنده severe hip pain والناس مشخصينه على انه عنده femoral acetabular impingement and then you discover inside ان هو لسه عنده البري راديولوجيكال ساينوفيال كوندروماتوز، البوديز ما بقتش كبيره قوي كويس انها تبان في البتاع. اتفضل.
Thank you, Mr. Chairman, and thank you for your kind invitation, Dr. Ahmed. وهننطلق سريعا. I have no disclosures about this lecture. And let we start. Synovial tumors are rare, benign or malignant growth arising from synovial tissue. It can occur in any joint, but hip joint is less commonly affected. It is important to be differentiated from other joint pathology due to treatment implication. And when I confronted with a rare situation, usually I prefer to use preferred items for systematic reviews and meta-analysis PRISMA guidelines to go in depth. So through the PubMed rapidly, if you put three keywords, if you put synovial and membrane and tumor, you will find 426 articles if you limit or filter your search for 5 years or full text. If you put another fourth word, if you put synovial and membrane and tumor and hip, you will find just 8 articles. So two narrative articles, review articles, I analyzed 6 articles. So the main synovial tumors of hip joint, tenosynovial joint cell tumor, chondromatosis, sarcoma, and the others are pigmented velonodular synovitis or lipoma arborescens. Rapidly through the synovial sarcoma, malignant mesenchymal tumor near joints, but usually arising from the synovium. Not usually arising from the synovium, it is usually multiple epithelial differentiation. So for clinical presentation, painful mass, swelling, sometimes systematic symptoms. For diagnosis, we use the MRI, guided biopsies, cytogenetics. Usually, we find a translocation between T, X, and 18 chromosome. What we plan for surgery, usually wide excision, chemo and or radiotherapy, and prognosis depend on size, grade, and metastasis if it is present. Pigmented velonodular synovitis, a proliferative lesion of the synovium with hemosiderin deposition, 2 types, mainly localized or diffuse form, presented by pain, swelling, recurrent effusion, and maybe stiffness. So the diagnosis depend on MRI. We will find in high resolution, hypointense lesions due to hemosiderin deposition, and usually biopsy confirming the diagnosis. And the treatment is usually wide synovectomy, and you should consider recurrence still a possibility. Lipoma arborescens is a benign lesion, villous proliferation of the synovium, fat infiltration usually present, and it usually occurred with chronic inflammation and recurrent trauma. Painless swelling, maybe effusions, MRI finding, you will find a classic frond-like fatty lesion intensity in the joint MRI, and we will go for synovectomy. Synovial chondromatosis, a benign metaplasia of the synovial membrane into cartilage nodules. Clinical features of hip pain, restricted range of motion, clicking or locking. And as Dr. Ahmed said before, synovial chondromatosis is stage 2-3 phases by Milgram to stage 1 active intrasynovial disease with no nodule formation. Stage 2, development of nodules in the synovial membrane, and stage 3, formation of loose bodies in the joint. So rapidly through the literature, variable studies reporting the arthroscopy role in synovial chondromatosis, systematic reviews, and large case series, and surgical techniques as we described. So rapidly I highlight this study and arthroscopy in primary synovial chondromatosis of the hip. And this was by the French team, Payot and his team. They included 120 primary synovial chondromatosis cases between 1985 and 2000. And the main follow-up was 6.5 years with the minimal follow-up of 111 patients. And they included arthroscopic-only patient in 69 cases, and both techniques arthroscopic and then open for 42 patients. Out of the arthroscopy-only group they evaluated, 51 patients has required no further arthroscopic treatment, and their mean age follow-up was younger and it was 39.4 years. And 18 patients of those had required repeated arthroscopic procedures. Out of the 111 patients, 19 patients had a required total hip replacement, and these are the 3 patients for arthroscopic only team, and they find 1 case of avascular necrosis after 12 years of follow-up and good outcome actually. 1 had ankylosing spondylitis, and 1 had multiple epiphyseal dysplasia. And out of these 111 patients, 63 patients had excellent clinical outcomes. So I just highlight our experience with the synovial chondromatosis in a prospective study case series between 2016 and 2020, the setting in our arthroscopy and sport injury unit at Asyut University, and beside 3 cases from Clínica Centro Madrid, Spain, and the arthroscopic debridement for synovial chondromatosis. And as Dr. Ahmed said, all patients are diagnosed as femoroacetabular impingement, so we did for them arthroscopic FEI, osteochondroplasty with suture ankle repair in all of those patients with 5-year follow-up. And here the diagnosis confirmed by clinical examination, positive Fader test, plain X-ray, MRI, and we go for arthroscopic debridement, removal of the loose fragments, and we did the classic osteochondroplasty and using old suture anchor techniques as our colleagues said before. And the results, we had no difference regarding age, size, gender, ASA classification, and no significant difference for surgical time, traction time, procedure performed, and hospital stay. So the minimum follow-up of 5 years, for those patients, we had 6 patients of primary synovial chondromatosis, also diagnosed as FAI and labral tear. Milgram stage 3 was in 3 cases, 2 in 2 cases, and 1 in 1 case. And the clinical outcome of them is improved from, for the WOMAC from the 61 to 24.5, and HOS score improved from 77.7 to 90.1. So the arthroscopic treatment of primary hip synovial chondromatosis in FAI patient yields in better pain control, offering less complication, ensuring rapid recovery. Maybe none of this small series requires conversion to total hip replacement. So the take-home message that the synovial tumors of the hip joint are rare. Diagnosis relies heavily on clinical suspicion index imaging and histopathology. Tumor-like conditions should be rolled out, especially chronic cases of septic arthritis and bursitis. Thank you.
شكرا جدا دكتور محمد. ندسكاس دلوقتي حاجه بحاجتها. We have 4 minutes. طب دكتور محمد. طب any questions؟
طب
اتفضل.
What about the recurrence rate? You didn't report on the recurrence rate.
About the recurrence through the literature or these small series?
لا في السيريز بتاعتكم
في السيريز one case out of 6.
في 5 years؟
Yes.
طب وفي الليترشر؟
في الليترشر less than 10%.
طب ايه البريكوشنز اللي بتعملها علشان توصل ان انت ريكارنس ريت؟ لان انا عملنا حالتين
Almost 100%.
الحالتين حصل لهم سيفير ريكارنس في خلال 6 شهور.
طيب يعني انا اقول لحضرتك هو اول حاجه الستيجنج، يعني جود كواليتي MRI الحقيقه بتفرق جدا في ان احنا نحدد هل دواء انتر ساينوفيال ولا لا. يعني دي نقطه مهمه. الحاجه الثانيه ان احنا طبعا بنبقى يعني كونسلنج البيشنت الموضوع دواء ريكارنت. الحاجه الاخيره ان if we confronted بالسيتويشن زي ما حضرتك قلت والعيل ما كانش عارف ان هو دايجنوزد، بنعرفه هذا الكلام طبعا especially لو كان ستيج 3. we should consider before surgery, especially لو في fake pain not only restricted to the anterior groin, maybe a lot of anterior hip posterior and there is no associated signs through the lumbosacral evaluation or something like that.
And for the 5 years, did you follow them up with an MRI after?
Yes. After 5 years, we did an MRI for them.
And what do you mean by in FAI patients? يعني هو someone who comes with hip pain and he has synovial chondromatosis, even if he has a CAM, even if he has a labral tear, I won't attribute this to his FAI because a lot of people have CAM. And why would you think you'd have to treat the CAM and the labral tear? or not focus on the main pathology, which is
Yes,
probably
the chondromatosis. Just we consider to follow up these patients, especially that they have both pathologies, because we find a chondromatosis maybe in a normal for the regards of FAI, there is no FAI, but we consider FAI in those patients especially as a subgroup to define if this recurrence again or if this only related to the FAI management through the FAI series that we have.
thank you.
تسلم ايدك.
Thank you.
شكرا يا
Thank
دكتور
you.
عبد الراضي.
Thank you.
عندنا بقى تو lectures على الديسبليزيا. اوكي. دكتور محمد كمال من اسيوط هيكلمنا على المين ديسبليزيا او الفرانك ديسبليزيا والمانجمنت بتاعتها. and then دكتور وليد النحال هيكلمنا على الانتيتي الجديده اللي احنا بنسميها بوردر لاين ديسبليزيا، والانتيتي الاجدد اللي هي الهيب instability which is the emerging era في المانجمنت بتاع الديسبليزيا. اتفضل.
Thank you, Dr. Ahmed, for the invitation. Management of adult hip dysplasia. This is a female patient, 33 years old. She has a right hip pain. She has been long treated as being rheumatoid. However, she has a special type of hip dysplasia, and we come back again to this patient. So the objective is to know the etiology, briefly the etiology, the anatomy, clinical and radiological evaluation, surgical options, and we'll show some cases. Usually, hip dysplasia can be a residual childhood CDH. However, more commonly, it is adult onset established dysplasia, and this is what is our topic today, and this is type that is usually overlooked. Commonly, it is superior lateral deficiency. However, it can be anterior, posterior, global deficiency. Acetabulum usually is anteverted. However, retroversions can be present up to 40% of cases. On the femoral side, especially if it is residual CDH, femoral head sometimes is smaller, with anteverted and short neck, with increased neck shaft angle, and cam morphology up to 40%. So as a result of the case contact between the head and the acetabulum, so the weight is being transmitted across a small area, and this increases the contact pressure across the acetabulum and leading to subcondylar sclerosis. On the other side, the labrum hypertrophied to overcover the uncovered head, so it is liable to tears, detachment, ossifications, and this predisposed to early osteoarthritis. So the natural history of untreated hip dysplasia is progression towards osteoarthritis, and usually in the Western countries, the most common cause of secondary osteoarthritis is untreated hip dysplasia. Clinically, mainly there is a groin pain. However, the site and the character of pain depends on the on the type of dysplasia, and we'll talk about this later. But mainly, there is usual groin pain increased with activity due to abductor fatigue or with static overload caused by prolonged sitting or standing. Sometimes there is catching, locking, or giving way when there is labral or chondral pathology by examinations. Antalgic gait if it is a labral tear. Trendelenburg gait, usually caused by abductor weakness. The range of motion can be normal, can be sometimes increased or decreased in some times of dysplasia. Special test, impingement test for the labrum, apprehension test for the deficiency. For example, the anterior apprehension test, we have a deficiency of the anterior, so by abduction and external rotation, so apprehension is positive, and the posterior apprehension for the posterior dysplasia. X-ray evaluation, the most important is to have a adequate, well-centered anterior-posterior view of the pelvis. The important radiological parameters, the lateral septal edge angle, normally it is about more than 25. Between 20 and 25, it is borderline dysplasia, and less than 20, it is dysplasia. Acetabulum index, normally up to 10. More than 10, it is dysplastic. The femoral head extrusion index, up to more than 25% extrusion of the head, uncovered head, this is in consistence with dysplasia. Sharps angle, more than 45 in dysplasia. The anterior and the posterior wall index, and here this is to measure the amount of coverage of the anterior and posterior wall, and the anterior wall index is more reliable than the anterior center edge angle in the false profile view. How can we measure the anterior and posterior wall index? For the anterior wall, by dividing the width of the anterior wall by the radius of a perfect circle of the femoral head, is normally about 0.04. Similarly, the posterior wall index is about 0.09. Acetabular retroversion, to diagnose acetabular retroversion, we need to have three signs. First is the ischial spine sign. The second is crossover sign more than 1 centimeter from the top of the acetabular to differentiate it from the cranial retroversion. And the third sign is the the posterior wall sign, and this means that the posterior wall is medial to the center of the head, and this indicates deficient posterior wall. So this is deficient posterior wall, this is posterior dysplasia, and this posterior wall sign differentiate the acetabular retroversion from the global overcoverage, in which there is anterior overcoverage and normal coverage of the posterior wall. A newly described sign for acetabular retroversion is called elephant ear sign in acetabular retroversion, and this is the shape compared to the normal acetabular. Don't forget to measure the neck shaft angle, sometimes increase, especially in cases with residual CDH, normally up to 140. Also, if you suspect anteversion, you need either MR or CT rotation profile for the femoral anteversion. MR orthography, you can, for labral tears, for the cam impingement, also you can show the hip subluxation or decentralization of the head that is present in such cases. So hip dysplasia is a 3D problem. So it's not only lateral coverage, so it's not only about the lateral center edge angle. There are many classifications for dysplasia. One of the important is Ottawa classifications, and depends only using the AP pelvis. So it can be anterior dysplasia. Here, the deficiency is anterior, so the lateral center edge angle is normal. The anterior wall index is less than 0.3, so deficient anterior wall. Usually, the patients have anterior hip pain caused by extension activities like descending stairs or wearing high heels. And usually, the anterior apprehension test is positive. Posterior dysplasia, the opposite. We now have a normally covered overcoverage of the anterior wall and deficient posterior wall. So the central edge angle is normal. The posterior wall index is decreased, less than 0.8. We have the three conventional signs of acetabular retroversion: ischial spine sign, crossover sign, and posterior wall sign. So the patient has anterior pain from impingement and posterior pain from the deficiency or for the subluxation posteriorly. Usually pain the posterior with flexion activities like ascending stairs, and usually the posterior apprehension test is positive. The most common type is the global dysplasia or lateral dysplasia. So here we have a deficient lateral center edge angle, and can be either anterolateral, posterolateral, or can be global dysplasia. So the pain is usually with static overload or with adductor fatigue, and this is the most common type. So treatment, either if there is no or minimal symptoms, we can apply non-surgical treatment, non-steroidal, avoid high-impact activities, physiotherapy in the form of abductor strengthening, iliopsoas strengthening, and uroflop. Surgical treatment, usually when there is persistent symptoms with limitation of daily activities. The aim of surgery is to improve pain, slow or stop the progression of secondary osteoarthritis, also to provide a better distribution of bone stock for possible further reconstructive surgery. Periacetabular osteotomy, PO, is the treatment of choice for hip dysplasia. The rationale is the reorientation of the articulating surfaces, so thus increasing the joint congruity, so allow load transmission through a wider area, decrease the contact pressure, so possibly reduce pain and possibly revert the degenerative change. It can be combined with femoral osteotomy if we have a high neck shaft angle or if we have a femoral anteversion. Hip arthroscopy can be used in borderline dysplasia, however, the role is still debatable. Also, if there is mechanical symptoms caused by labral tears or loose bodies, however, it does not improve the underlying osseous abnormality. Also, it can be combined with periacetabular osteotomy. So the first case is a female patient, 14 years old. She has a global dysplasia. The lateral center edge angle is less than 10, so it's severe dysplasia. Acetabular index more than 30, neck shaft angle more than 140. So we did a PO with proximal femoral varus osteotomy with improvement of the neck shaft angle and improvement of the acetabular index and lateral center edge angle. And this is 1 year after the periacetabular osteotomy, and we can observe improvement of the subcondylar scoliosis on the operated side compared to the non-operated side, indicating starting reversal of the natural pathology. A year later, we did the second left side, and now it's 4 years after bilateral periacetabular osteotomy and bilateral proximal femoral varus osteotomy. Second case, it's a female patient, 31 years old. She has a lateral center edge angle of about 20, femoral head extrusion index 40%, the normal MRA. So this, we can consider it as borderline dysplasia. And there's debate for a borderline dysplasia whether to do hip arthroscopy or to do a periacetabular osteotomy. However, she has a normal MRA, so my choice was to do a periacetabular osteotomy with improvement of the lateral center edge angle up to 34, and it can be done through a minimally invasive approach, smaller incision, and the patient can start weight bearing on the second day post-operative, partial weight bearing. So back to our first case. This is a female patient, 33 years old. She has a right hip pain. Actually, she has the 3 classical types of acetabular retroversion. She has ischial spine sign. She has crossover sign, 1 centimeter from the top, from the roof of the acetabulum, and also she has posterior wall sign. So this type is posterior dysplasia. She has anterior overcoverage. She has a deficient posterior wall. So this is posterior dysplasia. Also, for the MRA, she has anterior. She has a labral tear. So whether to do a PO, reverse PO, or to do arthroscopic or open rim trimming. This paper from the Bernays group. So if you have the 3 signs, ischial spine sign, crossover sign, and posterior wall sign, the better is to do a reverse periacetabular osteotomy. If you have a negative posterior wall sign, so you can do a rim resection. So we did, for these patients, a reverse PO with improvement of the crossover sign, decreasing the anterior impingement, and increasing the posterior coverage. So my take-home message, adult hip dysplasia is not an uncommon cause of adult hip pain. Early diagnosis and hip preservative surgeries helps to improve symptoms and avoid secondary osteoarthritis. You have to know the radiographic diagnosis, including different signs of different dysplasia, lateral, anterior, and posterior dysplasia. PO is treatment of choice, especially if there is usually for correction of the underlying osseous abnormalities. Hip arthroscopy in borderline dysplasia, or it can be combined with periacetabular osteotomy. Thank you.
تسلم ايدك. Let's بقى نسمع محاضرة الدكتور وليد النحال على البوردر لاين ديسبليزيا والهيب انستابيليتي. And then we have a good discussion على الانتيتي دي شاملة.
Thank you, Dr. Ahmed. هو يعني فعلا this is a new term that's been gaining a lot of popularity, and even now has a term hip micro instability. Let's start with the story of this 51-year-old lady who presented with right hip pain, was diagnosed with a labral tear, and was diagnosed with a CAM lesion, had a routine hip arthroscopy, labral repair, and a CAM resection. Then she came in 5 days after her procedure with increased pain and went straight to the emergency department. And this were her post-operative x-rays on day 5. So we can all see here that what's happened is a hip dislocation. So why would someone get a hip dislocation following a hip arthroscopy? That's what we'll be looking at and see what are the predisposing factors for this problem. Now, if you go into PubMed and if you search for the term hip instability, you will see that a wealth of papers that have been published over the recent period, exponentially increasing, particularly over the past 5 years. So when we're presented with a patient with hip pain, we have to look at 2 sides of the story. We have to
make a decision whether this patient is complaining of instability or is he complaining of impingement. They are two different categories that could be mixed up with one another. So to understand this, we need to know what is responsible for our hip stability. So this was described by Brian Kelly, and it's called the layer concept. So our first layer of stability is the bony coverage. And as Dr. Kamal Abdel Nasser said, it's not just about the lateral coverage, but also the anterior coverage and also the anteversion of the socket or of the acetabulum and the anteversion of the femur. The second layer is the static layer. Static layer is the labrum, the capsule, and the ligaments. The third layer is the dynamic layer, so that's the muscles, and one of the very important ones are the iliopsoas. And the fourth layer is the neuromuscular coordination of all of these together, and the thoracolumbar biomechanics. So when we're assessing someone with hip pain, and we're trying to figure out whether they're instability or impingement, there are certain clues that the patient might give us. So an unstable patient is usually a female, impingement usually a male. Of course, these are not rules. Yeah? Pain with instability usually happens when standing or walking. Pain with impingement is usually positional. Pain with instability is mainly lateral, while with impingement is mainly anterior. Patients with instability complain of a lot of clicking, snapping in their hips. And these patients, if they are performing activities, they're usually performing activities that promote a high range of flexibility and a high range of motion, such as gymnastics or ballet dancing. When we examine them, or any patient, we should now be doing a regular Beaton score. So the Beaton score does not test for hip instability, but it tests for generalized ligamentous laxity or hypermobility. And if a score is above 5 out of 9, then this is a hypermobile patient. The next is to look at the gait of the patient. If you look at the gait of this patient here, if you just subtly, you can see how there is some in-toeing in her gait. So this in-toeing denotes possible excessive excessive femoral anteversion. Excessive femoral anteversion could be a cause of instability. Again, when the patients sit down, you can look at their toes, and you can see when they in-toe their toes when they're sitting down, then they are trying to mask the anterior instability they might have in their hip. Log roll is a very important test, and it's basically testing the range of motion in the supine position. So you test it in internal and external rotation. If you have limitation of external rotation and abundance of internal rotation, this could be femoral anteversion. But if you have an abundance of external and internal rotation, then this could be instability, whether due to dysplasia or due to capsular or ligamentous laxity. Another important test is called the dial test. And let's look at the dial test together and let's see what's happening here. So you're pushing the hip in internal rotation. It should spring backwards to neutral. You can see how that right side did not spring backwards and the left side sprung backwards to a neutral position. So if it fails to spring backwards to a neutral position and have a firm end point, then this could signify capsular laxity. There's the hip apprehension test called the ABHERE test, and this is like the shoulder apprehension test. We're trying to stress the hip in a position that favors dislocation. So that's by putting it in abduction, extension, and external rotation, and putting force on the GT from backwards to forwards, and asking the patient if they sense anterior pain and a feeling of anterior instability. Imaging, AP pelvis is very important, but with these patients, it's not just important to get a supine X-ray of the pelvis, you also need a standing X-ray, particularly when you're looking for very subtle changes, because when patients stand up, then their femoral head coverage might decrease. So a normal looking acetabulum and normal parameters, you might find them to be on the dysplastic side when they stand up. And it's not just enough to look at an X-ray, you have to measure the X-rays. So if you look at this X-ray, it might strike you as a normal X-ray, but when you sit down and do the measurements, acetabular index is 13, and lateral central edge angle is 22. So this is a case of borderline dysplasia that could have been missed. And as Dr. Muhammad Kamal said, it's not just important the lateral coverage, but again the anterior coverage. So here you can see how deficient the anterior wall is, and the anterior wall index here is quite shallow, and how prominent the posterior wall is. So this is a case of possible acetabular anteversion which might cause anterior instability. There's another index called the FEAR index, or the femoroepiphyseal acetabular roof index, and that's looking at the roof of the acetabulum and its relation to the physeal scar of the femoral head. Normally, they should be parallel to one another. If they are diverging laterally, then this is a sign of lateral instability. Another new radiographic sign that was published in 2018 by Mark Saffron is the cliff sign, and that's opposite to the alpha angle and opposite to the cam lesion. So when you draw a best fit circle around the femoral head, then you will find a defect in the femoral head which might cause instability that's originating from the femoral side. There's also the traction views which are gaining popularity. So if you look at this is a 22-year-old female, and if you look at her acetabulum, she has no signs of dysplasia, but this is gentle traction without anesthesia when she's having an x-ray done, and you can see how her capsule is lax and how her joint is opening wide. So although she doesn't have bony instability, this patient has soft tissue instability. It's important to do the CT rotational profile, and as we said, excessive acetabular anteversion, this causes anterior instability and anterior hip pain. And if you can appreciate it on the x-rays by looking at the anterior and posterior walls, but you have to measure them also on the CT scan. So Lurch et al. From Bern, so they described the measuring the acetabular version using two cuts, one at the top of the acetabulum called the cranial acetabular version, and one at the center of the acetabulum called the central acetabular version. So this patient's cranial acetabular version here is about 40 degrees. Normally this should be around 0 degrees. The central acetabular version is 45 degrees. Normally this should be around 20 degrees. So this patient has significantly increased acetabular version, and you can appreciate that on her 3D scan. Again, excessive femoral anteversion. So excessive femoral anteversion again causes hip instability, and patients have to internally rotate their hip while they're walking to compensate for the feeling of anterior instability. And we can detect that when examining them by them having excessive internal rotation and limitation of their external rotation. And there's a lot of methods to measure the femoral anteversion. One of them is the Murphy method. This is the most common method. There are different methods, and whichever method you use, that's fine, as long as you know what the normal values are. So if you look at this 22-year-old fitness sports player, and you look at her, the acetabulum alone looks completely normal, but when you put the knees together in the same slide, you can see how internally rotated her knees are. When you measure the anteversion here, her femoral anteversion is 45 degrees. So this is another cause for anterior hip instability. MRI or MRA are important to looking into the soft tissue pathology, so labral tears or cartilage damage, and particularly with capsular redundancy, you need an MRA. So this is a patient that had previous hip arthroscopy and has a sense of anterior instability, and you can see that with the MRA, she has a defect that you can appreciate on the axial views and a larger defect that could be appreciated on the coronal views of her capsule. So how do we manage these patients? All of these patients need a trial of conservative treatment. So activity modification. So particularly if they are involved in sports, they should try as much as possible to avoid sports that favor flexibility and favor a high range of motion, because that is putting their hip at a disadvantage. They should focus more on sports that promote strength rather than flexibility. And they need to work with a specialized hip physiotherapist, someone who knows what they're doing, and try to increase the strength of the muscles and coordination of the muscles around the hip, and try to decrease or limit their flexibility. If we look at bony, if we look at surgical options, then we have three possibilities: either a bony procedure, a soft tissue procedure, or a combination of both. So bony procedure, as we would expect, and as we just heard in the last lecture, then it's fixing the underlying bony abnormality. So whether it's a PAO for dysplasia or rotational osteotomy for versional problems. But this is not usually our main problem. The main problem is we get a lot of borderline cases. So cases who have slight dysplasia, lateral central edge angle of 22, 23. So what do we do with these patients? And this is where it gets very, very confusing. And the literature so far has not been able to give us a frank answer on what we should do with these patients. So if you talk to someone like Benjamin Dome, who's in Chicago from the American Hip Institute, he advocates doing capsular plication for these patients with borderline dysplasia. And in this study, which he published in 2023, you can see that his 10-year results is an 82% survivorship of these patients, and he is reporting improved patient-reported outcomes in in the majority of his patients. But is this technique reproducible with everyone? That really here is the question. So if you do hip arthroscopy for borderline cases, then you need to know that you are only repairing the soft tissue component. You are not addressing the main bony component. You are giving them stability, but perhaps that stability is only for a short period of time because you have not addressed the main problem. And if you do that, then you definitely must not resect the labrum, because if you do resect the labrum, you are giving them instability. You should not cut the iliopsoas tendon, because if you do, then that causes instability. And if you do a capsulotomy, you need to be doing a minimal capsulotomy, definitely not a T capsulotomy. And if you do a T capsulotomy or an interportal capsulotomy, then you should be ready and prepared to repair that capsulotomy. There are certain instruments now available for repairing that capsulotomy. We don't have these instruments in Egypt, but we are able to do the capsular repair with the bird beak. A bit technically challenging, but it is still doable with the instruments we have currently available in Egypt. There's talk about capsular reconstruction in the case of a revision setting, whether with an autograft or an allograft. And basically, outcomes are favorable with the autograft more than the allograft. There's the other third line of management, which is a concomitant PEO or concomitant bony procedure with hip arthroscopy, whether hip arthroscopy is done on the same setting or 2 or 3 weeks prior to the bony procedure. Both techniques have been described in literature. So let's go back to our case. This is a patient that is 5 days following her hip arthroscopy. So why did this happen? So let's see, how can we avoid this from happening to us? So number one, we have to choose the patients wisely. We have to know whether our patient is an instability patient or an impingement patient. And we have to be very, very careful with females who present to us with isolated labral tears. Have to be very careful of this MRI report that is giving you a diagnosis of a case of femoroacetabular impingement with a labral tear with a small cam. The radiologist did not see the patient. The radiologist did not examine the patient. She might not be a case of impingement. She might be a case of instability. Hip arthroscopy might make her worse rather than making her better, particularly if it's done in a faulty technique and if you've resected the labrum, if you've cut the capsule, or if you've cut the iliopsoas tendon. We need to respect the soft tissue, so minimal capsulotomies. We need to focus more on doing more capsular repairs, particularly for the females, particularly for the ones which we suspect instability. We should not resect the labrum in cases of instability. We should not over-resect the bone. Our cams should be looking like a slope rather than a cliff. If cams that look like a cliff or pincer that have been over-resected could lead to instability or iatrogenic instability following our hip replacement or hip arthroscopy surgeries. Then I'll remind you again with what Professor Ahmed Hazem just told you. We have our cadaveric course coming up at the end of January. We'll have plenty of time to work on the cadavers and work on hip arthroscopy training with the cadavers. We'll have a whole day for that. And there are limited spaces because we have limited number of cadavers and we have limited number of instruments. So it's on first come, first served basis. Hoping to see you there, inshallah. Thank you.
شكرا جدا جدا يا وليد. So let's have a 5 minutes discussion on the hot topic. وعايز اقول لكم حاجه ان الايرا اللي جاي بتاع اليونج ادلت هيب بريزرفيشن هيبقى كله مايكرو انستابيليتي. يعني احنا بقالنا من سنه من 2000 جانز spoke about femoroacetabular impingement and then دخل الايرا بتاع فيليبون دخل الايرا بتاع الهيب ارثروسكوبي في الفيموراستابيلر امبنجمنت في مثلا 2005 6 و 20 years now we're speaking about femoroacetabular impingement for hip arthroscopy. So الايرا اللي جاي هنتكلم على المايكرو instability and this is how things happen. جانز كان بيعمل بيري اسيتابيولار اوستيوتومي، فلما كان بيزود الاوفر الكفرج اكتشف ان في اوفر كفرج، وبدا يفكر في العيانين اللي هم بييجوا يبريزنت بالاوفر كفرج سيمبتومز and then he thought about a normal patients اللي عندهم over coverage and then he thought about a cam femoral impingement. كل ده هي دروس هو اتعلمها من البيري استابيلار اوستيوتومي. احنا بنتعلم دلوقتي ان في انتيتي جديده اسمها المايكرو انستابيليتي من الناس اللي احنا بنعمل لهم هيب ارثروسكوبي، ودلوقتي this is a new entity جديده في الاياتروجينيك او let's say wrong patient selection، ان العيانين احنا we are inducing an iatrogenic micro instability. although ممكن يكون الموضوع متكبر زياده عن اللزوم، بس this is definitely an entity especially في العيانين اللي عندهم capsular laxity او ligamentous laxity, and once you think about it you will discover a lot of patients suffering from hip pain وساعات بيجوا present بسنابينج pain وهم عندهم instability. طيب نفتح دكتور محمد. دكتور محمد يسأل دكتور وليد.
الهيب instability after hip arthroscopy, was it iatrogenic instability or it was a missed hip instability from the start?
هي دي مش حاله، دي حاله كانت موجوده
انا عندي حاله كانت بوردر لاين ديسبليزيا وعملت لها هيب ارثروسكوبي وعملت لها ليبرال ريبير، والحالات دي لما بتخش بتلاقي الليبرم بتاعهم هيوج، وعملت لها فيري جود ليبرال ريبير بس ما عملتش كابسولار بلايكيشن وشي واز دوينج فاين لغايه بعد العمليه بحوالي شهر. كلمتني قالت لي انا او بعدها بشهر ونص لما بدات تحط ويت بيرنج بدات قالت لي انا البين زاد جدا وبتاع، عملت لها اكس ريز لقيتها سبلاكست، وساعتها قلت لها تعالي نعمل كابسولار بلايكيشن كويس، لان غالبا كنت هعملها لها اوبن حتى ده الكلام ده من حوالي 2 أو 3 سنين، والعينه اختفت. غالبا هي سافرت، هي كانت عارفه انها هتعمل بيري استابيلار اوستوتومي وغالبا هي راحت لحد او سافرت عملت بيري استابيلار اوستوتومي ليتر اون.
One of the causes of the anterior dysplasia is excessive rim resection. يعني ده يمكن اكتر سبب للانتيريور تايب يعني.
دكتور عبد الراضي.
شكرا على الديسبليزيا والكفرج بتاعها والمايكرو انستابيليتي ايتمز. بس ليه سؤال يا وليد بالنسبه للإليوسوس ريليز، هل الإليوسوس ريليز انتو دو از روتين اور مش بتكلم في البوردر لاين؟
يعني هي فعلا كان جت فتره وكانوا سموا الإليوسوس قال لك ده البايسبس بتاع الهيب، وزي ما البايسبس انا مش بتاع شولدر فسوري لو انا قلت، انا كنت برضه فاهم ان البايسبس كان كله بيتعمل له تناطمي وبعد كده الناس بطلت. فالإليوسوس في الهيب has passed with the same phases. With everyone says, the iliopsoas tendon looks inflamed, so just cut the iliopsoas, and they will only feel some weakness for 6 weeks, and then they will improve. And then things have shifted. Number one, iliopsoas has become identified as an important stabilizer of the hip. So if you cut it, you might be causing instability. And the reason it being inflamed could be because of instability. Yani why is it inflamed? Because
روتين كنا بنعملها روتين في اي حالاتنا قبل كده.
And what about capsular closure or repair? Is it a routine?
انا عملت حاله واحده.
Thank you, Professor Ahmed, and you can go now for the final. Thank you.
question بس اخير.
هو بالنسبه حضرتك تقصد ايه بالريفيرس بيري استابل استيوتومي؟ هو ده معناه كوركشن اوف ريتيرفيرتد استابيلوم ولا ايه؟
الريفيرس هو المفروض الاوريجين ديسكريبشن فور ذا بيري استابل استيوتومي is to increase the after coverage and somewhat increase the anterior under coverage. حالات البوستيريور ديسبليزيا هو الفكره الاندر كفرج كله بوستيريور. الفكره ان انت بتعمل الاتجاه العكسي.
طلع الاستابل انتيريور، طلع انتيريور بقى.
ريفيرس ده استابل استيوتومي بتزود الانتيريور كفرج، بتزود البوستيريور كفرج، بتقلل الانتيريور كفرج. بتعمل انتي فيرجن يوجوال ديسكريبشن كان الديفينيشن مينلي انترولاترال. انت بتقلل
الريتروفيرجن. بتزود
الريفيرس هو العكس.
الريتروفيرجن.
Okay, now our final presentation about does hip arthroscopy work. So I will try to provide the evidence, the indication and the outcome of hip arthroscopy and what we have recent literature in the recent literature nowadays. So the hip arthroscopy, if we search on the hip arthroscopy in PubMed, we will find that this curve with an exponential growth of the publications after the year 2000. So before the year 2000, this was simple and sporadic cases for for removal of loose bodies, very sporadic cases found in literature. However, after the era of the Gans described femoroacetabular impingement, and concerning femoroacetabular impingement, الباثولوجي اللي Gans described في femoroacetabular impingement was so precise in it was not revised. يعني he described cam pincer with the deformity or the cartilage injury في each type. It was very precise لدرجة ان ما حدش جه بعديه وعمل لها revision in spite ان احنا دخلنا في era hip arthroscopy we can see better, we can describe better, لكن it was very precise. So if we look at the hip impingement era, we will find that most of the hip arthroscopy after the year 2000 was described for hip impingement. طيب لو بصينا كده أخذنا 2004, 2014, 2024, so after every 10 years you will find that the number is almost time 100. So it's 11, 170, 173, and then 400. So I mean there is an exponential growth in the publications concerning this technique. So the key question is, does it truly improve the outcome compared to alternatives? Let's first speak about the indication. So the first indications of the hip arthroscopy nowadays, or the highest indications, is treatment of femoroacetabular impingement and labral tears. Again, removal of loose bodies, synovial pathology, like this case I just went inside and suffering from hip arthroscopy, and I found this shape. I was going as a femoroacetabular impingement case, and then in the fovea, I discovered that it has a synovial chondromatosis, what I name preclinical or pre-radiographic stage. And then early cartilage lesions, and finally some trauma fixation that we're doing nowadays. So what's the evidence based? If we compare the hip arthroscopy to physical therapy concerning the treatment of femoroacetabular impingement, the physiotherapy focus always on posture, improving the posture, core muscle strengthening, hip strengthening, and lower body flexibility. This is how the physiotherapy thinks. While surgery restore the hip biomechanics and anatomy. So the RCTs says that the arthroscopy is superior to physiotherapy alone in femoroacetabular impingement concerning pain and function, with a better reported patients' scores. However, the limitations is that it's less effective in advanced cases, advanced osteoarthritic cases. And these are two RCTs, one coming from multi-center studies in the UK and another one coming from multi-center studies in the US, 2018 and 2019. And both of them has concluded that arthroscopic surgery led to a greater improvement with a statistically significant difference than physiotherapy. So what about conventional surgery? We know that the classical or the traditional treatment way of femoral impingement was at the years of invention or the years of description was done in the hands of Gans using an open trochanteric flip or safe surgical hip dislocation. With the following advantages, that it has a global view, increased visualization, together with good templating of the cam. However, its disadvantage is that it's highly invasive and necessitates an osteotomy of the trochanter with a long post-operative recovery and a long hospital stay. The complications was reported up to 9%. Most of them is related to the trochanteric osteotomy with a malunion or a non-union, adhesions, resection of the ligamental arteries. Nowadays we are stating that it's a cause of microinstability, and reoperation for removal of hardware. So that was the traditional way of the surgical dislocation that we will compare upon. If you look at the two graphs from PubMed, that you will find that the surgical hip dislocation, although most of them are nowadays done for things other than femoroacetabular treatment, you will find that we are playing with, till the year 2025, within 100 publications per year. However, this is 4 times, about 400 publications for hip arthroscopy concerning femoroacetabular impingement as the only disease treated only. So, what's the evidence based? For me, I do both, the surgical hip dislocation and the hip arthroscopy. However, there is definitely an improved visualization in my hands regarding the hip arthroscopy. So I can see minor tears at the periphery from the undersurface. While dislocating the hip or doing a Smith-Peterson approach, you look at the labrum from above, so you cannot see the minor tears. Together with the huge magnification the arthroscopy provides, gives you a peculiar view of the chondrolabral junction. Literature-wise, arthroscopy provides, of course, short hospital stay. It's a day case surgery, less time off from work, faster returns to sports, faster recovery, and a better clinical outcome, especially at the short term. Which is better radiographically? The literature evidence-based states that there is no radiographic difference regarding the bone resection in arthroscopy than in open surgery. So, this is a very important outcome, which is the return to sports. Nowadays, most of the femoroacetabular impingement, especially in young adults, are surgery for sports medicine. So the current evidence suggests that about from 80 to 90%, 85% in average, returns to the sports after doing a hip arthroscopy, with almost from 50 to 80% of them returning to the pre-operative levels. So now we're competing with the knee sports medicine or the shoulder sports medicine. This is the same numbers as the knees and the shoulder. With an average return, and this is very important, within 7 months in average, plus or minus 4 months. So usually when I do a hip arthroscopy, I state to the patient that if you're playing sports, there is a chance of 80% of returning to the same sports after doing the operation. Within about half a year, start to rehabilitate for the next season after 7 months. So what about the patient-reported outcomes in general? Studies yields a remarkable short-term and intermediate term regarding the hip arthroscopy for improvement of the patient function. But there is a very important thing. Patient counseling is very important because this is the curve of the patient expectations. I'm doing a hip arthroscopy. I'm expecting a very, very rapid recovery. And actually, the road to recovery is like this. So please state to the patient that he's doing a big surgery through a small incisions. So there is a huge, a very complicated road of recovery. And we're expecting recovery within 7 months to 1 year at least. If we compare long-term, patient-reported outcomes is not extensively investigated. However, evidence suggests that there is efficiency that is coming in 10 years. So, how to achieve a good outcome? There is a success factors. And we always mention that miss one of the 3 success factors, your outcome will suffer. Proper patient selection, surgical expertise, and the post-operative compliance. to have a proper rehabilitation program. Not every groin pain is a femoroacetabular impingement. We're suffering from the epidemic of femoroacetabular impingement. Remember that there is a lot, this area of groin is a complex area with multiple diseases other than femoroacetabular impingement. If you do a perfect operation on a wrong patient or a wrong diagnosis, you will definitely have a failed result. So the second thing is that remember that the poor outcome reported in literature for older patients more than 45 years, this is very important. If he's suffering from a long journey, protracted disease course, more than 2 years of symptoms, and osteoarthritic joint, large acetabular chondral defects, or arthritic or cartilage, hyaline cartilage damage, together with the relative indications like obesity, females, and poor mental health. This is a very important article in the CECO-J discussing hip arthroscopy in osteoarthritic joints. And this is very important in our community because most of our patients, they come pre-arthritic. Actually, they differ from other communities or other races that comes early. So don't promise too much false expectations. That's the conclusion. Good results when cartilage damage is limited to the periphery only. And they define the poor prognostic factors, patients more than 50, advanced chondral damage, radiographic osteoarthritis, and they mentioned in the paper that you have an advanced, the poor results will achieve after TONUS stage 3, and I think it's only stage 1. Joint narrowing more than 2 millimeter, and cases where you have chondral defects at the femoral head, subchondral cysts, subchondral edema, and posterior translation of the femoral head. Surgical experience. The hip is a deep-seated joint, and it's a demanding procedure. You have to have a high experience to reach extremities of the joint, like the inferior part, the far lateral, far medial, or the posterior cam. Together with the lower the experience, the higher the complications. So many papers investigated the learning curve, and they delineated the learning curve as the less time the surgeon will take in his operation with a better patient-reported outcome. The exact cutoff point was defined previously as 30 cases with a very steep learning curve. And now in recent papers, it reached up to 300 cases to be an experienced surgeon. So I mean, as we do more, we define that the learning curve should be better and higher and higher. Success factors. This is a very important thing. We're not doing an operation without rehabilitation. The patient has to be very compliant to the post-operative rehabilitation protocol, which defines in early phases as the protective phases, as you are protecting your operation, your repair, together with maintaining a flexible joint. And then going more towards a stability and rehabilitation of the joint, which will take up to 5 months after the operation. Complications. Generally considered safe procedure, the hip arthroscopy. However, there is no procedure without risk factors. It's an anatomical and surgical procedure is complex, and the current estimated complications rate ranges in literature between 0.5 to 6%. Most of the complications turn around the nerve injuries. Direct nerve injuries is rare, but this is serious. So either you injure the femoral nerve or the sciatic nerve. However, the traction-related nerve injuries, they are very common and usually they are transient. And now we're moving from the posted traction to the postless traction, and most of my surgeries now is using no post, and it's doing perfect. Chondral injury. I always mention that introducing a scope into the hip joint is a very easy job. The technical issue is how to introduce it without injuring the cartilage, because you're introducing the hip arthroscopy instruments in a narrow corridor between the hyaline and the femoral head. So the technical skills is to introduce it without making chondral damage. Finally, the repair. it's not only about tying the labrum, it's tying a labrum to function afterwards. So repair of a functioning labrum. So repairing the labrum very near to the articular surface is the target, so as to have a good suction seal afterwards. So other less common complication like heterotopic ossification, which is usually non-significant, persistent pain after the operation, and a revision surgery. So the current consensus says that hip arthroscopies work best for femoroacetabular impingement, labral pathology in young active patients. Poor outcome in advanced arthritis. Evidence supports improved functional and pain relief in a carefully selected cases. So that's the summary, is that it works good for femoroacetabular impingement as well as treatment of labral pathology, but it's always associated with poor outcome in advanced arthritic cases, and the evidence supports that you select the case to have a good outcome. Thank you. Any questions? أنا متشكر جدا لحضراتكم، وكنا very very fruitful session بجود discussion على 3 مواضيع سواء femoroacetabular impingement أو dysplasia أو outcome. Thank you.